Sham, give me a hands up when I have to start.
Yes, ma'am. Yes, ma'am. Ma'am, we are live, ma'am.
So, good evening and a warm welcome to one and all for the Thyroid Clinics session. We are grateful to have you with us today for what promises to be an enriching session on thyroid health. To start off today's session, we'll be showing a brief video on the Indian Thyroid Society. So, this video symbolizes the society's mission, the ongoing initiatives, and the impact we strive to make in the field of thyroid health. So, I request the tech team to please play the video.
तस्य भासते सर्वमिदं विभाति।
Thank you. The Thyroid Clinics is currently being led by our esteemed coordinators, Dr. Pramila Kalra Madam and Dr. Roma Pradhan Madam, whose definite dedication and leadership has guided us towards the excellence in patient care and education. A warm welcome to you, ma'am. We are honored to have several dignitaries with us today. Dr. Krishna Sheshadri, sir, who is the president of Indian Thyroid Society, Dr. Arun Menon, sir, who is the secretary, and Dr. Mini, ma'am, who is the treasurer. So we are deeply grateful for the invaluable contribution of our esteemed dignitaries. Definitely, their leadership and guidance have been instrumental in shaping the direction of our work. So we are also joined by our dedicated team members, Dr. Chitra Madam and Dr. Vijay Reddy, sir. So together we strive to bring the latest insights in thyroid care. We also invite you to submit your research to our flagship journal, that is the Thyroid Research and Practice. So here is the QR code. Simply scan the QR code to upload your details and share your valuable work with us. We look forward for your contribution, which will help advance the knowledge and practices in thyroid health. We also invite you to become a reviewer for the Thyroid Research and Practice. So, again, scanning this QR code will help you contribute to your expertise to achieving research in thyroid health. Again, your insights and feedback will definitely help maintain the high standards of our journal. So now let's go to the today's programs overview for today's session. So we have the case presentation presented by Dr. Ashwini, who is a senior resident in the Department of Endocrine Surgery from King George Medical College, Lucknow, with Dr. Amit Agarwal sir, Dr. Anand Mishra sir, and Dr. Pooja madam moderating and guiding the session. So it's also a pleasure to have Dr. Madhukar Mittal sir, who will deliver his talk on the molecular testing for thyroid cancers, which will be followed by an interactive quiz. Dr. Sumana Reddy will be leading on this engaging quiz at about 8:45. So moving forward, let's get started. So I'd like to invite Dr. Vijay sir to introduce the moderators for the case discussion.
Good evening, Dr. Ganavi. Today we are having an interesting case discussion on the topic of outcome of locally advanced DTC. And to present this, we have Dr. Ashwini Rahalkar, who is a third year MCH resident, Department of Endocrine Surgery, King George's Medical University. And the session will be moderated by Professor Amit Agarwal, sir. So, sir is now Director, Department of Endocrine Breast Surgery, Medanta Hospital, Lucknow. He's been a past president of ITS and ISOES and Indian Association of Endocrine Surgeons. He successfully trained more than 70 endocrine breast surgeons. Next. So, co-moderating this session will be Dr. Anand Mishra, sir, Professor and Head, Department of Endocrine Surgery, King George's Medical University, Lucknow. And the next moderator will be Dr. Pooja Ramakant, who is Professor, Department of Endocrine Surgery, KGMU, Lucknow. She is Editor-in-Chief of Indian Journal of Endocrine Surgery and Research, and she's Vice Dean Innovation Intellectual Property Cell of KGMU. She has more than 100 indexed medical publications and more than 20 Best Paper Poster Travel Awards in various national and international conferences. Over to Dr. Ashwini Rahalkar. You can start the presentation.
Good evening, everyone. And I would like to thank the Indian Thyroid Society for giving me this opportunity to present this interesting case of locally advanced thyroid cancer today. Is the screen visible?
Yes, Ashwini ma'am. You can do the slideshow.
Okay, thank you. So this is a 65-year-old postmenopausal lady who presented to us in September 2021. She had a long-standing goiter with rapid increasing in size since the past 3 months. She also complained of dysphagia, voice change, and breathing difficulty, which was there since the past 3 months. She did not have any comorbidities and no significant family history. This is the clinical image of the patient in which we can see the left lobe of the thyroid is enlarged, measuring 15 into 10 centimeter, extending 3 fingerbreadths below the angle of mandible up to the left clavicle and laterally extending up to the sternocleidomastoid. It has a nodular surface, which is hard in consistency with restricted mobility on deglutition. The lower border is palpable and there is tracheal deviation to the right. There are multiple enlarged level 3 and 4 cervical lymph nodes, and carotid pulsations are absent on the left side, which is positive Berry's sign. So based on the history and clinical examination, this is we are dealing with elderly lady with a long-standing goiter with rapid increasing in size and compressive symptoms. On examination, it is a hard fixed mass with multiple enlarged lymph nodes and positive Berry's sign on the left side. So clinically, this would be a thyroid swelling, which is most likely malignant in etiology. The patient was evaluated elsewhere. An ultrasound of the neck was done, which showed enlarged left lobe of the thyroid with multiple nodules, solid hypoechoic, wider than taller with irregular margins and few foci of calcifications. Largest nodule measuring 8 into 7 centimeter. It was a TIRADS 5 lesion. She also had multiple enlarged cervical lymph nodes, level 3 and 4, largest measuring 2 into 2 centimeter. A guided FNAC from the thyroid nodule as well as the cervical lymph node was done outside, which was reported to be papillary thyroid carcinoma. We got a core needle biopsy done at our institute, which was suggestive of a follicular neoplasm. To look for operability, we went ahead and did a cross-sectional imaging, and contrast-enhanced CT scan of the neck and thorax was done, which showed a large heterogeneous, just a second, which showed a enlarged left lobe of thyroid along with the left cervical lymph nodal mass. Together, it measured 7 into 7 into 14 centimeter. Here we can see there are foci of calcifications, which is typically seen in cases of long-standing goiter. The trachea is pushed to the right and also it is compressed. It also had infiltration and erosion of the thyroid lamina. Here we can see there is encasement of the carotid artery on the left side and there is non-enhancement of the internal jugular vein on the left side, suggesting a thrombus involvement which extended throughout the length of the IJV. And posteriorly, the planes with the prevertebral fascia were also not maintained. And the patient had multiple nodules in bilateral lungs, which was likely to be metastatic lesion. So here we are dealing with initially thought to be a locally advanced malignancy, also had lung metastasis, so turned out to be an advanced thyroid carcinoma. In view of inoperable disease in the form of carotid encasement and ill-defined planes with the prevertebral fascia, we decided to start her on tyrosine kinase inhibitors and was started on tablet sorafenib, which she took for 5 months. However, there was no clinical and radiological response to sorafenib, so the patient was switched to lenvatinib. She received lenvatinib for 10 months. After that, the patient developed cough with expectoration, low-grade fever, night sweats. She was evaluated and found to have pulmonary tuberculosis in January 2023. This is a major problem. A lot of our patients in India especially have this diagnosis of pulmonary tuberculosis. So she was started on anti-tubercular therapy for 6 months. At the same time, lenvatinib was continued. With lenvatinib, she eventually developed hand-foot syndrome and gluteal abscess. She also had newly detected hypertension and hypothyroidism for which she was managed. Patient eventually complained of persistent headache. On evaluation, she was found to have clival metastasis, for which radiation oncology neurosurgery consultation was sought. Neurosurgery did not have any active surgical intervention, and radiation oncology decided to give her 2 fractions of whole brain RT. In October 2023, we got a repeat contrast enhanced CT scan of the neck and thorax done, in which there was partial response in the form of reduction in the size of nodule. The nodule had come down to 43 into 34 into 63 mm. However, still there was erosion of the thyroid lamina. But here we can see the carotid, which was completely encased at the index visit, now had abutment of up to 180 degrees. And posteriorly, the planes with the prevertebral fascia were also showing just abutment and no infiltration. So in view of progression of the disease, in view of clival metastasis and partial response to the primary site, and because of side effects of tyrosine kinase inhibitors, we planned the patient for surgery. Intraoperatively, the left lobe of thyroid was 8 into 6 centimeter. Multiple nodules were seen. Right lobe was 2 into 2 centimeter. The straps were stuck to the specimen, so had to be excised during surgery. We also did a left-sided modified radical neck dissection for her. However, there was no plane for dissection over the left carotid artery, and the thyroid lobe was stuck to the thyroid artery, to the carotid artery. So decision was taken to go ahead and do a debulking surgery. Post-operatively, the histopath came out to be follicular thyroid carcinoma. Here we can see extension of the tumor beyond the capsule, which was widely invasive, and none of the lymph nodes that were excised with MRND specimen were positive. So as per the dynamic risk stratification, the patient belonged to high risk disease group because of one was widely widely invasive FTC with incomplete tumor resection and distant metastasis. With this, she was started on thyroxine suppression to maintain a target TSH of less than 0.1 milli-international unit per ml. So eventually she was initially started at a dose of 125 microgram of levothyroxine, which was gradually increased up to 250 microgram to meet the target TSH suppression. She was also started on lenvatinib. She received 100 millicurie of radioactive iodine ablation in January 2024. In the thyroid uptake scan, there was uptake only in the thyroid bed, and none of the distant metastases were taking up the radioactive iodine. So post radioactive iodine ablation, the patient was referred again to radiation oncology department in view of gross residual disease, R2 resection, and 5 fractions of external beam radiotherapy were also given. In this year, August 24, she was actually planned for the next dose of radioactive iodine ablation. However, this time on withdrawal of thyroxine, she had increase in the clival metastasis. And because of that, she had abducens nerve palsy and developed lateral rectus palsy and diplopia, which was managed with oral steroids. And eventually she has improved, and now there is no diplopia. The patient also complains of pain in abdomen. Her evaluation was done and ultrasound was done, which was suggestive of cholelithiasis with cholecystitis. And currently, she is being evaluated and planned for a laparoscopic cholecystectomy. On her biochemical evaluation in January 2024, her stimulated thyroglobulin levels were 64,200 with a normal anti-thyroglobulin levels. And on a repeat biochemical evaluation in October 2024, her thyroglobulin levels have come down to 442 and TSH is in the target suppression range, that is 0.1. So in summary, we have a 65-year-old lady with long-standing goiter with recent rapid increasing in size with compressive symptoms. CT suggestive of inoperable disease with lung metastasis. She was started on TKIs, had pulmonary tuberculosis, managed for pulmonary tuberculosis, had progression and developed clival metastasis, planned for surgery. Debulking surgery was done on thyroxine supplementation. Received 1 dose of high dose of radioactive iodine ablation in the form of 100 millicurie, and also developed radiotherapy to the post-operative bed. During when planned for second dose of radioactive iodine ablation, She had worsening of clival metastasis, and because of longer duration of tyrosine kinase inhibitor, she developed cholelithiasis with cholecystitis. So there are a few learning points that we get from this patient. One is the increased progression-free survival with TKIs. Now, since almost 3 years, she is with us on tyrosine kinase inhibitors, and she is doing good. She is able to manage her daily living activities and is having a decent quality of life. And worsening of metastasis can occur with withdrawal of thyroxine, especially in critical areas like brain and spinal cord. For this, the treatment is actually only with oral steroids, but we have to be careful when we are planning on thyroxine withdrawal for such patients. And third is that actually cholelithiasis with cholecystitis is not a very commonly reported complication associated with tyrosine kinase inhibitors. However, it can still be present, and we need to have a higher index of suspicion for the same in patients who are receiving tyrosine kinase inhibitors for a longer duration of time. So this is her photo taken just this week, where the patient, as we can see, is doing fine and happy. So just a brief review of literature. For differentiated thyroid carcinomas, actually there is a FDA approval for 3 drugs. First approval was given for sorafenib in 2012, where there was statistically significant progression-free survival with sorafenib as compared to placebo. However, the overall survival was not statistically significant. In case of lenvatinib with select trial, it got an FDA approval in 2015. Again, it showed a progression-free survival of 18 months versus 3 months in placebo group, which was statistically significant. But overall survival was again not changed even in the lenvatinib group. And cabozantinib has gotten FDA approval for management of DTCs in 2021, where progression-free survival is again statistically significant as compared to the placebo group. There are few reported adverse effects of the TKIs, which includes palmar-plantar erythrodysesthesia, most commonly observed with sorafenib, the management of which is usually done with hand and foot protection, application of urease cream, and moisturizers in the form of petroleum jelly. Also, pain relief medications should be given to the patient. Other skin lesions without palmar-plantar erythrodysesthesias also are most commonly seen with the sorafenib group itself, and that is usually treated in the form of oral steroids or topical steroids along with oral antihistaminics. Diarrhea is one of the most commonly reported gastrointestinal complication with TKIs, for which it is seen more commonly again with sorafenib, and it can be managed with loperamide alone. For nausea, there is as such no particular treatment recommended. Metoclopramide may be given in select patients, but usually nausea is not as worse to cause any discontinuation of therapy. Hypertension is very commonly seen in tyrosine kinase inhibitors, most commonly seen in lenvatinib. So it is recommended that index baseline blood pressure of the patient has to be monitored, and only in with controlled hypertension it can be started. In cases of resistant hypertension, it is advised that the tyrosine kinase inhibitors should be stopped. Patient should be treated initially with either ACE inhibitors or beta blockers. Once the blood pressure is controlled, then the patient can be safely restarted on tyrosine kinase inhibitors. And there are few reports of fatigue and weight loss. There are no specific management lines for the same, and neither is there a plausible explanation regarding the adverse effects related to fatigue and weight loss. So this is the multicentric study conducted across 4 major centers of endocrine surgery in India, where the response to tyrosine kinase was evaluated. The partial in cases of sorafenib and lenvatinib, both the partial response rate for sorafenib was 71%, and for lenvatinib it was 43%, although it was not statistically significant. Progression-free survival was 30 months for sorafenib group and 35 months for the lenvatinib group. Again, not statistically significant. Adverse effects were more common in the sorafenib group as compared to the lenvatinib group. And overall survival, as mentioned in all these studies, has not actually changed. So this is another article from study from TMH Mumbai, in which they have just measured the outcome of DTC on TK, not specifically done a subgroup analysis for sorafenib or lenvatinib, in which partial response or complete response was seen in almost 77%, and progression of the disease was seen only in 16% of the patients. However, adverse effects were seen in 70 patients, but only 16% of the patients required discontinuation of therapy because of the adverse effect profile. This is our own experience of tyrosine kinase inhibitors that we have given in our center. The overall survival for the DTC group was 30.6 months, and progression-free survival for patients of DTC in our study group was 21 months. And the adverse effect profile.
Yeah, go ahead. I think we can have some time for discussion. So you can have this slide after this. We can have.
Yes, sir. Last
Yeah.
slide.
Yeah.
So, as for the adverse effect profile in lenvatinib, the most common adverse effect that we saw, and maximum number of our patients have gotten lenvatinib, was fatigue. And as compared to that, cholelithiasis was seen only in one patient. Same with sorafenib and cabozantinib. Sorafenib mainly presented with fatigue, and in cabozantinib, majority of the patients had palmar-plantar erythrodysesthesia. However, we actually had not had any reason or any toxicity profile which warranted stopping of TKs in our patients.
So thank you, Ashwini, for a very interesting case. So just a couple of points. As we all know, TKIs are really game changer for these locally advanced breast cancer. I can recall a decade back, these patients would hardly survive for 6 months. The quality of life is poor. They can hardly swallow their own saliva. But with TKIs, they have good swallowing. They are not dyspneic and they can do their daily course. So it is really a game changer. The only difficulty is to when to decide to stop these drugs. So I have a question for you, Ashwini. Do you think you could have continued for 6 months more and then perhaps operated? You could have got a R1 or an R0 resection?
So probably, but the patient already had received TKS for a duration of 2 years now.
Yeah.
And because of the partial response, we decided that we'll go ahead. And she had worsening of distant metastasis in the form of clival metastasis. That was the reason mainly why we decided to go ahead with surgery first.
Yeah, so as you said, it's always a dilemma when to stop it, and so there's a very narrow window when you can operate on these patients after giving neoadjuvant lenvatinib or other TKIs, So that window is really difficult to decide, but it was good that at least palliation was provided in this patient. The second point is that when you said withdrawal of lenvatinib, withdrawal of thyroxine caused worsening, perhaps use of thyrogen can, overcome this situation if the patient can afford it, So that's just a point for the sake of discussion.
Yes, sir.
There, the worsening of metastasis will actually not take place. And cholelithiasis, yes, in my experience also, I have not come across this complication, which is not so common as you already mentioned in literature. So TKS, yes, we have to really use. And sorafenib, I found really not a good drug. After lenvatinib and cabozantinib, I think sorafenib is no longer being used for advanced thyroid cancer. But yes, cost is a factor. They're much cheaper than the lenvatinibs. The third point is, in today's time, perhaps genetic testing would allow you to give a more specific, these TKI, lenvatinib, these are multi-kinase inhibitors, But if you get a genetic testing and if you find that the BRAF is mutated or HRAS is mutated, you can, or NTRK fusions are there, you can give a specific inhibitor, which will be more effective like serpelcatinib and parozentinib, those kind of drugs would be more useful. So perhaps in time to come, when these drugs become available in India, a genetic study. So this is for the viewers, even genetic studies in sporadic thyroid cancers have a lot of value now, Normally you would not associate doing genetic testing for thyroid cancers, but in sporadic thyroid cancers, especially these locally advanced thyroid cancers, that really helps you to, titrate and see which TKIs to actually use, and they are more effective, less side effects. The problem with TKIs, they are very, they have a lot of side effects, and if you really titrate, can I ask you what the dose, average dose for your patient was?
So we started with 24 milligram.
She could continue with 24. That's very
Yes, sir.
unusual.
Yes, sir.
Yeah,
She
because
could
our Indian
actually.
patients, really giving them 24, they have a lot of diarrhea and hand-foot syndrome, and very few patients will actually get the full dose. So you really have to titrate it down to 10 milligrams or 14. But effective dose is actually 24 if they
Yes, sir.
can actually take it. So Western patients can take 24, but most Indian patients don't tolerate this kind of dose. So I think these are my few observations, but it was really a good case that exemplifies the modern management of thyroid cancer. As I said, 1 decade back, these were hopeless cases. It was like death sentence for them. But now, good quality and quantity of life, as shown by our patient who's still alive after 3-4 years.
Yes, sir.
Pooja, you have any comments?
Yes, so thank you, sir. You rightly said, and now today we are using multiple modalities. In this patient, we have used radio iodine, radiation therapy, surgery, tyrosine kinase inhibitors. So I think today's era of precision medicine, as you said, that if we know the genetic mutation, we can target specific those mutations also, and
So you have
thyroxine
to go
suppression
full
also.
throttle as you went for. But it was interesting that patient had actually radioiodine uptake, but otherwise these are usually radioiodine refractory kind of cancers.
Yes, sir. And then surprisingly, in her FNA said papillary carcinoma, and then final histology was follicular.
But there was
So
no poorly differentiated element in the follicular.
No,
surprisingly, there was no. We asked pathologists to regross because clinically we suspected that it was hard and fixed.
So I think for all medical endocrinologists as well, again, I'll emphasize these are no longer hopeless cases. Send it to the right person. And maybe, it's kind of disciplinary management, the endocrinologists and the endocrine surgeons. Rather than sending these patients to medical oncologists, I think the endocrinologist and endocrine surgeons together can manage these patients and provide good palliation for these patients. 3 years for a locally advanced thyroid cancer with a good quality of life is amazing.
So in fact, in her, our neurosurgeons didn't operate, but I was seeing clivus metastasis. Even they can be from the base of the skull surgeries. People have attempted surgeries. So they have done better than no surgery of metastasis.
Yeah. So again, the point to be emphasized is now we are accumulating experiences. We have data, even though it's quite modest, but yet it gives us the feedback how the patients fare, what are the complications, what is the average dose they tolerate. So the good collection of data can give us more information how to tweak your management of these patients.
Yes, in fact, in one of our patients, we had tracheostomy fistula also. So we have seen all spectrum of complications of TKIs.
Yeah. Yeah, I mean, it's
Hmm.
really surprising how even old men who couldn't, as I said, swallow his own saliva is now alive after 3 years. So these patients do very well with the TKIs. The only thing is they need frequent visits to you. You have to titrate the dose, manage their complications. Hypothyroidism, hypertension, hand-foot syndrome, these are quite common. Diarrhea is very common. So these are the commonest side effects in our Indian patients.
Thank you, Dr. Ashwini, for this wonderful case presentation.
thank
So,
you so much.
shall we move forward now?
Can I,
to the next?
can I have a question or a comment?
Sure.
So Amit, very interesting that we had a similar patient. Two comments. One is that I mean, sometimes we look at the skin lesions as benign, but they can progress to Steven Johnson's in some of these. So I would
Yeah.
be very careful.
Yeah.
In fact, we had to discontinue lenvatinib, and then there is also cross reactivity. So when we stopped the lenvatinib and tried to reintroduce sorafenib, it reoccurred.
Okay, that's
And in
interesting.
fact, this patient aerodigestive invasion, nobody would touch him. In fact, I saw him after 4 years, and people had just told him nothing could be done. and
Right.
then now this patient on everolimus. So I mean that is a last resort, but that is one thing. The second question is there is some older literature and about the TKI inhibitors restoring iodine sensitivity. Uh, and it has always been a question of how long does it do the so one of the things is that if somebody's on a TKI inhibitor, should we at some point of time relook at it, relook at iodine uptake to see if adjuvant iodine therapy can be given in some of these patients?
So that was salumetinib, that was the which causes reiodination, induces reiodination, but not these TKIs. Only selumetinib has been seen in the trials.
I think there's some data with sorafenib also,
Okay.
but I haven't seen it with the newer ones.
No, but that I don't know the literature, but as in this case, she had a radioiodine uptake.
Oh, she did.
Yeah.
So the ones that I'm talking, the one that I'm dealing with had no radioiodine uptake.
But that's an
And
interesting
sternal,
thought.
and
Yeah.
interestingly, it was sternal,
Yeah.
and the thoracic surgeon would not touch it because he felt that it had gone into the sternum.
Yeah.
One interesting thing is that when you stop the TKI inhibitor, there
They
is a
grow.
quick climb back of
There.
the.
Oh, they grow so fast. Yes, true. Yeah, that's a problem. You reduce the dose and they start growing. That's so that titration is very tricky. Yes.
Fabulous case. Thank you.
Thank you. So, in fact, our nuclear medicine colleagues are using TKIs in radioiodine refractory thyroid cancer patients with the view that they may become sensitive again. So, they are giving TKIs.
So has it been shown objectively that they become
There
radioactive?
is literature. So, there is literature. So, on that basis, they are sending to us and asking to give TKIs.
Yeah.
But we started just 1.5 years back. So, it's too early to comment on our patients, how they have done.
Good. Okay. Thank you.
Thank you. Any more comments? Any more queries? Do we have any questions?
No, ma'am. Not
So
any.
shall we start with the second session?
Yes, ma'am.
So yeah, it's my pleasure to introduce Dr. Madhukar Mittal for the next session. He is currently professor and head Department of Endocrinology and Metabolism at AIIMS Bhopal. He has 51 national and international publications, 15 book chapters, and he was also former head Department of Endocrinology at KGMC Lucknow. So I welcome him for an interesting topic, molecular testing for thyroid cancer, which is very pertinent after this case of differentiated thyroid cancer. Dr. Madhukar Mittal.
Yeah, thank you, Dr. Roma, and thank you to the Indian Thyroid Society for having me here. And that was an interesting case which we had, which sort of sets up the whole thing. Let me try and share my slides. So are my slides visible?
Yes, sir. You can go that slide mode karna, sir. Slide show. Yeah.
Please.
So is that fine?
No, sir. Not this one, sir.
It's in, okay.
Yeah, just this done. Good to go, sir.
Okay. Right, thank you. So we'll be discussing about molecular testing for thyroid cancer, its applications and the recent advances. Yeah, so if we look at thyroid cancer, we have differentiated thyroid cancer. Predominantly, the majority of this is papillary thyroid cancer. Then we have follicular thyroid cancer, the poorly differentiated forms. You have the others, anaplastic and medullary thyroid cancer. But what we'll be focusing on today is the differentiated thyroid cancer and its various variants. So the differentiated thyroid cancer accounts for around 90% of all thyroid cancers, and there has been an increasing incidence over the last decade. A lot of it in some centers has been due to the non-selective use of neck ultrasound and FNACs. So there's a screening bias. So more and more are being picked up. in much earlier stages. So a lot of these thyroid cancers have excellent long-term prognosis, for which it is even suggested that overtreatment be avoided. But if you look at the history of molecular testing, you had the BRAF mutation analysis as the first molecular test developed for thyroid nodules, followed by the RAS. Then you had the gene expression classifier in 2012, followed by thyroglobulin mRNA testing and the NGS coming up. And then 2014, the Thyroid Cancer Genome Atlas sort of expanded this further. So initially in the 90s, where you had this proof of principle, which expanded further with regards to progression of molecular tests for thyroid nodules and cancer. And with the Thyroid Cancer Genome Atlas and the advanced genetic sequencing, you have a lot of mutations for thyroid cancer being identified to the tune of up to 90% or even more. So this genetic landscape of thyroid cancer has advanced, and the commonly dysregulated cell signaling pathways include the MAP kinase, the PI3 kinase pathways, and the WNT pathways, amongst the others which are there. So if you look at this progressive oncogenesis model, we can see from the follicular thyroid cells, you have differentiated thyroid cancer, be it papillary or follicular. And then you have these multiple hits, which can even progress to poorly differentiated varieties. And then various epigenetic phenomena adding to the anaplastic forms of thyroid cancer. So this sort of sequential model sort of gives a simplified version of it. So let's go ahead as to why we need molecular testing for thyroid cancer especially. Thyroid cancer is the commonest endocrine cancer, with prevalence in India in thyroid nodules ranging from 12 to 15%. In the initial evaluation, we do a thyroid function test, ultrasound, and a cytology, where only around 15% prove to be malignant. However, there is a significant chunk which gets indeterminate results on cytology, so around 10 to 25%. And this is where clinicians have a dilemma as to what to suggest to the patients further, because in these patients, the malignancy risk may be seen in 1/6 to 1/3 of these patients who get indeterminate cytology. So ambiguity persisting regarding management of cases reported in these indeterminate diagnostic categories, where they are reported as atypia of uncertain significance, follicular lesions of undetermined significance, a follicular neoplasm, or suspicious for follicular neoplasm, although these terminologies are about to be changed as and when it gets published in literature. But as of now, this is the last terminology. So this is the one which I have highlighted, which is the atypia of undetermined significance or FLAS or follicular neoplasm, which sort of where the molecular diagnostics initially sort of took off. The malignancy rate ranged here from 5 to 15% and 15 to 13% here. So what was offered was a repeat cytology, a repeat FNA, or an ultrasound follow-up, or even a diagnostic surgery in the form of a lobectomy was suggested. But what has been added on now is molecular testing to sort of stratify or identify the patients who actually, with the use of molecular testing, can be picked up, so that 1/6 of those 1/3 who actually have malignancy can be picked up much earlier. So what to do when you have the diagnosis of an indeterminate thyroid nodule, where these Bethesda 3 and 4 nodules, more than 2/3 are benign, but still you have 1/3 where you need to take care of in terms of malignancy risk. Diagnostic surgery, as I mentioned, lobectomy, which was done, is actually not cost effective, with involvement of surgical risk and potential post-operative consequences, especially for the 2/3 who are of those nodules which are actually benign. So 2/3 of the individuals will go on to have unnecessary diagnostic surgery. So we can try and sort of screen them. Molecular testing, a combination of genomic, transcriptomic, or microRNAs to assess the risk of malignancy. Its use, especially predominantly in the West, there's been a major use, has resulted in a significant reduction in the rates of diagnostic surgeries by up to half to 2/3. And currently, the three commonly used molecular tests are the Thyrosec version 3, a Afirma gene expression classifier, and a combination of Thigen Next and Thyra MIR. And there is recent literature, liquid biopsy, which is upcoming but still not established. So if you look at this, the Thyrosec is the one which is commonly used. And then you have, which is based on the NGS, then you have the Afirma, and then you have the combination of Thigen-X and Thyra MIR. So let's look at the technologies for this. The Thyrosec version 3, it's a targeted DNA and RNA next-gen sequencing covering 1,112 genes plus more than 120 fusions. It has a good sensitivity of 94% and a specificity of around 82%. If you look at the Afirma, which is RNA NGS mRNA expression based, 1,115 genes expression, along with mutation hotspots and fusions. Here the sensitivity is around 91%. The specificity is lower at 68% here. And then you have the combination where a targeted NGS is done, and this is done sequentially. And mRNA expression is done actually where the targeted NGS is not able to pick up thyroid cancer. It's not done in all cases. Here, the overall sensitivity is 93% with a specificity of around 90% here. And these have been validated in various studies, although the validation studies have been questioned, especially for the Afirma and the combination Thigen Next and Thyra MIR. So which tissue, if we are using molecular testing, which tissue to be used? It's done in the FNA tissue samples or in the formalin fixed paraffin embedded samples. Primary and metastatic thyroid cancer usually maintain the same driver mutation, so it can actually be done from the tissue obtained even from metastatic samples as well. It's also been tried for peripheral blood, the liquid biopsy samples as well. So based on the sensitivity and specificity, some of these tests are used predominantly to rule out and some to rule in. And if you look at the combinations, we talked about the sensitivity and specificities, the Thyrosec and the combination Thigen-X MIR, they score pretty well if for both the concepts of ruling in or ruling out the disease. Where if you look at the fourth, which I didn't talk about, the Rosetta, it's predominantly to rule out a thyroid malignancy. So just a bit about the combination one, where you have the, it's a two-part molecular test where first the Thigen Next is offered. And if it is negative, then the MIR is reflexly done. So this is how it is. Indeterminate nodules going on Thigen Next. And if you have a no detectable or weak mutation, that is when you go for the microRNA expression. If a strong mutation is initially detected in the NGS sample, then one can take a decision for going straight away for surgery rather than for the microRNA expression. The Rosetta GX, based on the microRNA non-coding RNAs implicated in gene regulation, measuring 24 microRNAs using the thyroid FNA smear here. Here, the sensitivity and specificity ranges to around 70% here. And it's not widely used. The other ones are more widely used. What about the Indian setting? Because these are actually not available in the Indian setting. So MedGenome had come up, I think it's 1.5 years with a ThyroTrack test, which is an NGS-based sequencing assay, which covers the single nucleotide variants and intronic deletions along with fusions. So although their site mentions all across, but we have to be careful when we are using molecular testing, especially in the cytology cases. So it's the indeterminate ones, 3 and 4, where this test should be applied, because if it is clearly benign, you don't need, because the yield is very poor. And if it is malignant cytology, then actually there is no need to do for a molecular testing. However, in certain cases, as we'll discuss, beyond cytology, molecular testing is also done. So the sample requirements again for ThyroTrack, FNAC fluid, an RNA latter, tissue, or the FFPA tissue block. The limit of detection here is 5% VAF for synchronucleotide variants and the intronic deletions. The panel inclusion here is much limited as compared to the previous Western ones. 46 genes here for SNVs and intronic deletions, 23 genes analyzed for fusions. The sensitivity here is 98% for these particular identified variants. So let's look at when to do this molecular testing and whether the scope is expanded beyond just cytology. So to rule in and rule out malignancy in indeterminate intermediate cytology of the thyroid nodule. So patient should be counseled regarding potential benefits and limitations of molecular testing prior to doing this test. And if intended to take a decision on this, it is suggested by the American Thyroid Association that it should be performed in certified laboratories by CLIA and CAP. So the ACE recommendations, not recommended in nodules with established benign or malignant cytology. And this I'm talking of cytology alone. Molecular testing should complement, not replace cytologic evaluation. And the results are especially when they are expected to influence clinical management. That is when this becomes really, really important. So with regards to an approximate risk of malignancy for each mutation and fusion, we can have varied risks. And that is where, as Dr. Amit Agrawal and Dr. Pooja were mentioning, this personalized medicine is taking off actually, and will sort of take off even further with targeted therapies being available now. So actually this molecular testing, especially in these indeterminate thyroid nodules, is really, really helpful in picking up those 1/3 cases. So risk refinement for suspicious for papillary carcinoma cytology, it can really alter the surgical decision, especially if positive for BRAF, RET, PTC, and other mutations where the estimated risk for malignancy is really, really high, more than 95% or beyond, and should be considered similar to cytologically diagnosed thyroid carcinoma in cases where the estimated risk for malignancy is high. What about molecular testing at initial management by providing prognostic information to guide extent of therapy? And this is what we were discussing in regards to the previous case as well. So where this molecular testing can actually help. So utilizing the genetic information in deciding the extent of surgery, and also in administration of radioactive iodine ablation, that is where molecular therapy is also having a greater role to play, especially in future as well. With regards to the BRAF V600E mutation, is the most common driver mutation in papillary thyroid carcinoma and its variants. And there is compelling evidence that this mutation is associated with aggressive histopathological features like extrathyroidal invasion, lymph node metastasis, and recurrence of the disease. So if one is able to identify this mutation, then one can take a decision with regards to a more aggressive surgical course. Combination of one of these TERT promoter mutations or RAS mutations carries worse prognosis than either single mutation alone. And these combinations may thus justify a more proactive approach to initial management of patients. So where these TERT promoter mutations are associated with aggressive tumor features, so combination brings together a more proactive approach to initial management. So the risk stratification, although we say in terms of percentages, but actually it's becoming a continuum with individual mutations being identified and then individual risk being placed. So it's actually a continuum, and this sort of will be the future for personalized care and personalized medicine. So this spectrum goes on getting expanded for aggressive subtypes of thyroid carcinomas, maybe even medullary, poorly differentiated, and anaplastic. having high disease-specific mortality. In patients with differentiated thyroid carcinoma developing metastasis, where radioiodine therapy is the standard of care. However, we know that 70% of these tumors lose this radioactive iodine avidity and become resistant. So there again, this molecular testing can play a role. Progressive thyroid carcinoma on radioactive iodine therapy may be stable on thyroid suppressive therapy. So all these roles are getting expanded. Recognition of important molecular drivers and signaling pathways has led to development of molecular targeted therapies. And this we discussed as in our previous case as well. So multi-kinase inhibitors acting on several kinases. We talked of sorafenib, lenvatinib, and cabozantinib. But monokinase inhibitors are also on the way with more selective inhibition of single kinases with favorable efficacy and limited side effect profile. And some have been approved by US FDA for treatment of advanced thyroid cancer. So if one has a molecular basis to using a particular monokinase inhibitor, that could help specifically our patients with regards to personalized medicine. So it is actually changing our practice, molecular testing, to identify a targetable genetic alteration. In the West, especially, there's a trend towards early molecular testing in patients with locally invasive or metastatic disease. Use as neoadjuvant therapies before surgeries for patients with inoperable or surgically high-risk locally invasive thyroid cancers, or even as redifferentiating agents for those refractory to radioiodine therapy to subsequently enable them for radioactive iodine therapy possibility. So this is just a slide to show the various kinase inhibitors here. And if we can see the immune checkpoint inhibitors here in blue, and you have the multi-kinase inhibitors in yellowish orange here. But what the world or the future holds is these targeted therapies, the monokinase inhibitors. And here the molecular therapies may actually play a role in identifying the specific level of the mutation and whether the individual drugs would help benefit individual patients for better survival. So these are just a list or a slide showing the various studies with regards to genetic alteration based targeted therapies. I'll not go into details with regards to the kinase inhibitors.
I'm so
here.
sorry to disturb Dr. Madhukar. The time it's exceeding. We have to have a quiz also. If you can just wrap it up if possible.
Sure. We'll do that. So just a couple of slides here. These are some of the FDA approved molecular targeted therapies. And to summarize here, there has been a significant progress in identifying the mutational markers of thyroid cancer over decades, and especially with the Genomic Atlas post 2014. You have a host of numerous specific mutations being identified in thyroid cancer. But interestingly, BRAF or RAS, we say that, but more and more BRAF-like or RAS-like sort of being identified with a combination of molecular markers being identified in individuals. So this is what will shape the future. So the initial classification, which was based on cellular origin, the anatomic or pathologic morphology, the TNM staging. Now we are moving from beyond even to mutational status to molecular pathways and gene expression profile. And the future may be even tumor immune phenotyping here. So three main molecular approaches: testing for somatic mutations, gene expression evaluation, and the microRNA-based classifiers. This is what we need to do. Identify a test to rule in or rule out based on specificity, sensitivity, and predictive values. Afirma, Thyrosec, and a combination Thygenex, ThyroMIR are there, and ThyroTrack in India. The diagnosis of thyroid nodules with the indeterminate cytology, identifying underlying driver genetic alterations, and helping to choose a specific genetic alteration-based therapies based on monokinase inhibitors is the future. Just so take-home messages so that I end quickly. Molecular testing of thyroid nodule and cancer has improved the diagnostic accuracy. Its role has expanded in deciding the initial extent of surgery, the prognostic importance of various molecular markers, which can alter the approach to follow-up, and more insight in targeted systemic therapies after discovery of various molecular variants and fusion forms, leading to personalized care in thyroid cancer and better survival for our patients. So I'll end here. Thank you.
Thank you, sir, for a very informative and enlightening talk on this novel topic. I do not see any questions here. Do the other panelists or the faculty want to pose questions to Madhukar, sir? Or should we move on to the next session?
Yes, in the interest of time, to all the students waiting eagerly for the quiz.
Yes, ma'am.
Now, in inviting Dr. Sumana Unnuru Reddy, who's an associate professor in the Department of Endocrinology in NIMS Institute in Hyderabad. So these are the rules of the quiz, and Dr. Sumana will take us through them. Over to you, Dr. Sumana.
Firstly, I would like to thank Indian Thyroid Society for giving me the opportunity today. So, can we proceed with the quiz?
Yeah.
Okay. Oh, I'm supposed to brief. Okay. To participate in the quiz, click on the button, which is the attend quiz button, and then given on the screen, which is being live streamed. The quiz is being conducted through a platform called Slido, and you are requested to use a laptop for ease of experience. And this quiz will run for 5 minutes, and it contains 10 questions. The quiz master will display case or description of question by screen sharing. And then there will be 10 questions, and each question will be given 30 seconds time. And then kindly do not refresh the page or go back onto the page, or else all your answers can get lost.
Ma'am, you can go ahead and screen share the questions.
Oh, okay. Can I screen share? Yeah.
Yes.
Just 1 second. Are you able to see my screen?
Not yet, ma'am.
Oh, not yet. Just. Can you now?
Yes, we can.
Yes, ma'am.
So here we start with the quiz. The first question is, which one is not one of the protective methods used for thyroid protection during iodine 131 MIBG treatment of the other tumors like neuroblastoma or so on? And the options include A, potassium iodine, B, methimazole, C, levothyroxine, D, steroids. I'll wait for the queue to move on to the next question.
Yes, ma'am. I'll let you know, ma'am. Yeah.
Yeah, sure.
Yeah. Ma'am, we can move on, ma'am. Yeah. Second question.
And the second question is, which genetic syndrome is associated with an increased risk of papillary thyroid carcinoma, multinodular goiter, Sertoli Leydig cell tumors, pleuropulmonary blastoma, and cystic nephroma? And the options include A, Cowden syndrome, B, familial adenomatosis polyposis, C, Carney's complex, and D, Dicer 1 syndrome.
Next question.
Yeah. There's a clinical question. A 37-year-old man is found to have a left thyroid nodule, and the ultrasound reveals a 4.6 centimeter hypoechoic nodule without any calcification or hypervascularity, and also without any suspicious lymph node. FNA of the nodule reveals follicular neoplasm, which is Bethesda class 4. Repeat FNA biopsy with molecular analysis reveals a red PTC rearrangement. So what is the next step in the patient's management? The options include A, referral for lobectomy, B, referral for total thyroidectomy, C, referral for total thyroidectomy with bilateral neck dissection, and D, repeat FNA biopsy in 6 months.
Next question, ma'am.
Sure. Active surveillance is increasingly advised for low-risk papillary microcarcinoma, and which statement is true regarding active surveillance of papillary thyroid carcinomas? Option A includes patients with PTZ and multiple lesions are not candidates for active surveillance. Option B, women who are desiring pregnancy are not candidates for active surveillance. Option C includes invasion into strap muscles warrant surgery. Option D is presence of parathyroid disease which requires surgery is an indication for thyroid surgery.
Next question, ma'am.
Yeah, sure. So, which genetic mutation is most commonly associated with dyshormonogenesis in congenital hypothyroidism? Option A, TSH receptor gene mutation. Option B, DUOX2 gene mutation. Option C, PAX8 gene mutation. And option D, NKX21 gene mutation.
Ma'am, next question, ma'am.
Sure. The question is, a 32-year-old man with widely invasive follicular thyroid cancer undergoes total thyroidectomy, followed by radioactive remnant ablation using 150 microcurie of iodine 130. And then he subsequently develops lung metastasis and is treated with an additional 200 microcurie of iodine 131 with an objective decrease in the size of the lung metastasis and reduction in the serum thyroglobulin levels. So which of the following is the most likely adverse effect from this patient's radioiodine therapy? Option A, azoospermia. Option B, hypoparathyroidism. And option C, increased risk of dental caries. Option D, leukemia.
Ma'am, next question, ma'am.
Sure. Which of the following statements is true regarding the production of iodine 131? Option A, iodine 131 is produced directly from uranium fission. Option B, iodine 131 is produced by neutron irradiation of tellurium. Option C, iodine 131 is synthesized from stable xenon isotopes. Option D, iodine 131 is formed by the radioactive decay of cesium 137.
Ma'am, next question, ma'am.
So, which statistical features qualify for rule out test? Option A, high sensitivity, high negative predictive value. Option B, high specificity and high negative predictive value. Option C, high sensitivity and high positive predictive value. Option D, high specificity and high positive predictive value.
Ma'am, next question.
Sure. In the context of thyroid eye disease, Barrett's index is typically measured using imaging techniques. So, which of the following statements best describes its clinical significance? Option A, it helps predict the risk of corneal ulceration due to exophthalmos. Option B, it assesses the degree of optic nerve compression by measuring intraocular pressure. Option C, it quantifies the enlargement of extraocular muscles within the orbit to assess thyroid eye disease severity. Option D, it determines the thickness of the orbital septum as a predictor of thyroid eye disease progression.
Ma'am, next question.
Okay, here is the last question. Which thyroid nodule test has a two-step testing process, including both genetic mutation testing and microRNA expression analysis? Option A, Thyrosec GC, and option B, Afirma. Option C, Thygen Next, and with Thyra MIR. Option D, none of the above. So, at least 3 questions have directly been covered in the topic. So,
Ma'am, it's done, ma'am. Yeah.
So this is the end of the quiz. More than 60% of the questions are related to thyroid cancer, keeping in mind with today's topic. Yeah. Thank you. So, ma'am, should I go ahead and discuss MD quiz answers?
Yes, Dr. Sumna.
So just
Mr. Sham, can you try and share the slides of the...
I think it just got opened. Okay. So now I'm going to reveal the answers for the quiz, which was conducted for MD physicians. The first question is, which is not an indication to treat subclinical hyperthyroidism? Options were osteoporosis, atrial fibrillation, heart disease, and peripheral neuropathy. The correct answer is D, peripheral neuropathy. So I'm just going to quickly run through the answers as we are in short of time. The second question was, what is the condition associated with calf muscle hypertrophy, muscular weakness, elevated creatinine kinase levels and high TSH levels in a child. Options were Kocher-Debre Semiline syndrome, Pendred syndrome, C. von Wijk-Krumbach syndrome, D. Hoffman syndrome. The correct answer is A. Kocher-Debre Semiline syndrome. The muscular pseudohypertrophy is a very characteristic feature of this condition. And this muscular hypertrophy happens not only in the calf muscles, but it also can be seen in the arm muscles and even in the facial muscles, giving a very athletic appearance to the child. Diagnosis is very important because this can be confused with the primary muscular dystrophies in children. So TSH testing is very important even in the muscular conditions. And the third question was, a 46-year-old woman with long-standing hypothyroidism is referred because of increasing levothyroxine requirements. Previously, she had maintained her TSH with 125 mcg. However, over the past 2 years, her requirement is as high as 600 micrograms, but still without good biochemical control. She reports strict adherence. However, on physical examination, there is no goiter, but a large abdominal mass is noted, which extends into pelvis. The tumor is most likely to contain excessive amount of which of the following mutation. So options include monocarboxylase transporter 8, option B pendrin, and option C sodium iodine transporter. Option D is type 3 deiodinase, which is also the right answer. So the type 3 deiodinase, its main function is to deactivate the active hormones, which are T4 and T3. T3 is usually expressed in the fetal tissues or like liver, cerebral cortex, etc. And it is also expressed in the placenta. And in the placenta, its function is mainly to block the T4 levels from mother to the fetus. So thereby preventing the exposure of fetus to excess of thyroid hormones. However, it goes into dormant state in adult life, but this can get reactivated in several disease conditions like inflammation or cardiac hypertrophy and mainly many tumors. So this expression of this enzyme can lead to a state of consumptive hypothyroidism where there is high TSH and low T4, and also high reverse T3. So this high reverse T3 is the characteristic feature which can clinch the diagnosis. And also one more interesting feature about this disease is usually patients will require very high amounts of levothyroxine to to achieve biochemical euthyroidism, because it is a consumptive hypothyroidism. All the T4 and T3, it keeps on getting deactivated. Normally, in adults, we would give a dose of 1.6 microgram per kg. In children, about 10 to 15 microgram per kg in the neonates. But in this condition, they might require even up to 30 microgram per kg to control the disease. And then fourth question is, what is the recommended time frame for newborn screening to detect congenital hypothyroidism? Options were within the first 24 hours of life, option B between 48 and 72 hours of life, and option C is after 1 week of life, and option D is at 6 months of age. And the correct answer is between 48 and 72 hours of life. This is mainly because by this time period, the initial surge of TSH levels which occurs in the neonates, that would subside, and thereby it prevents the false positive and false negative results. And the fifth question is, at what age is it recommended to reassess thyroid function to confirm the need for continued treatment in congenital hypothyroidism? Options A, 3 months, and option B, 1 year, option C, 3 years, and option D, 5 years. The correct answer is option C, 3 years. Because this is mainly because by this age, the brain development, which relies heavily on thyroid hormone, is largely complete. So thereby, this allows us for a period of temporary withdrawal of thyroid hormones, and then we can do our investigations and then decide whether to continue treatment if it is a temporary or if it is a transient state or a permanent condition, permanent hypothyroidism. And the sixth question is, the 42-year-old man is referred for the following TFT. TSH is 12.1, free T4 is 1.3. He is asymptomatic and findings on physical examination are normal. And the further investigations reveal a negative TPO and negative thyroglobulin antibodies. And thyroid ultrasound is also normal. One of the patient's 2 children also has a similar laboratory results. So which of the following is the most likely cause of this patient's abnormality? Options are A, adrenal insufficiency. Option B, excess selenium exposure. Option C, resistance to thyroid hormone. Option D, TSH resistance. And the correct answer is TSH resistance. So this is also known as a familial non-autoimmune hypothyroidism. Large TSH elevations are generally found in patients with homozygous or compound heterozygous mutations. But however, the T3 and T4 levels are within normal limits, including free hormone levels. And thyroid ultrasound is also normal, but very rarely even modest hypoplasia can be seen. So basically, it is an familial non-autoimmune hypothyroidism. And the 7th question is, what is the main site for levothyroxine absorption? Options are stomach, A, option B, proximal small intestine, option C, distal small intestine, and option D, large intestine. And the correct answer is distal small intestine, C. So biotin interference can produce the following thyroid function test pattern. So option A is low TSH, high free T4 and high T3, and option B, low TSH and normal free T4 and T3. Option C, normal TSH and low free T4 and T3. Option D, high TSH and low free T4 and low T3. So the correct answer is low TSH, high free T4 and high T3. So biotin can produce a thyroid function pattern exactly simulating hyperthyroidism. It is not only that, it can also cause false elevation of thyroid stimulating antibodies. So the picture can mimic the Graves' disease. And this happens mainly when the dose, when you are taking a very high dose, because the normal recommended dose is about 30 micrograms. But all the hair and nail supplements, which generally are used by the people, they contain a very high doses, and this can lead to this kind of thyroid function pattern. And we have to stop the medication for 2 to 7 days and then repeat the testing. The 9th question: all of the following increase iodine requirements in pregnancy except option A, increased renal iodine clearance. Option B, elevated maternal thyroid hormone production. Option C, transfer of iodine to the developing fetus. Option D, decreased maternal thyroid binding globulin levels. Correct answer is decreased maternal thyroid binding globulin levels. In fact, TBG levels actually increase in pregnancy. It is not the decrease, but however, it does not directly impact the iodine requirement in pregnancy. And the last question for the MD quiz: teprotumumab has been approved against thyroid eye disease, and it acts against which receptor? Options include A, TSH receptor, option B, IGF-1 receptor, option C, epidermal growth factor receptor, and option D, vascular endothelial growth factor receptor. And the correct answer is IGF-1 receptor, which is option B. This has been approved, and it has been shown to be very effective in improving proptosis and clinical activity score. And why this is used? Because the patients with the Graves' disease, they overexpress the IGF-1 receptor in their orbital fibroblast, B cells and T cells. Thereby, thereby it can lead to the production of inflammatory cytokines like interleukin 6. In addition to hyaluronic acid and other extracellular matrix molecules, thereby it leads to the soft tissue expansion, both in the fat mass as well as in the muscular tissues in the eye, in the orbit. So this brings us to the end of the MD quiz answers.
Ma'am, we have the winners, ma'am.
Yeah, sure.
If it is okay, I can share the screen, ma'am.
Sure.
We can stop your screen share, ma'am. Yeah.
Okay, man, just one. Yeah, I stopped sharing.
Thank you, Dr. Sumana, for taking us through a brilliant quiz. And the winners of the quiz, which was held for practitioners, the first place goes to Umani Saumya. Your email ID is flashed there. So, and the second place goes to Kavyashri Velchuri. Congratulations, winners. And thank you, Quizmaster, for taking us through the answers so patiently. With this, may I now request you to share the answers for the DM quiz?
Yeah. Sure, ma'am. Just one second. So the answers for the DM quiz. So for the first question, can I directly go to the answers instead of repeating the question? Just or should I?
Yes, ma'am.
Yes.
I think we can see the questions.
Yeah. Since we have. So the correct answer for the question 1 is steroids. This is so. When treating certain tumors with iodine 131 MIBG, thyroid protection is necessary, as this can is necessary to prevent radioactive iodine uptake by the thyroid, which can lead to thyroid damage. And this is especially relevant in children because many of these neuroblastoma and all, the iodine 131 MIBG is given as a part of treatment. And so these children will be rendered hypothyroid for the life. So many have been tried. This is the famous DBR regimen called dilute, block and replace. Dilute with potassium iodide and block with methimazole and replace with levothyroxine. So the correct answer is, steroids have been tried, but they have not shown much response. So, and coming to this is the relevant reference. And this is the second question asking for the syndrome of multiple thyroid conditions along with the other tumors. The correct answer is Dicer-1 syndrome. The Dicer-1 syndrome is characterized by ovarian Sertoli-Leydig cell tumors, pulmonary blastomas, lung cysts, cystic nephromas, embryonal rhabdomyosarcomas, benign and malignant thyroid lesions. Amongst the thyroid conditions, MNG is the most common condition. And the lifetime thyroid risk of thyroid cancer is 16 times high. Follicular variant of papillary thyroid carcinoma and minimally invasive follicular carcinoma are common. And the most cancers occur before 40 years, the peak incidence being 10 to 20 years. So cancers can occur as early as in the second decade. So screening of the ultrasound is recommended at 8 years for this condition. And the third question was a clinical question where FNA reveals for Bethesda class 4 follicular neoplasm with a repeat FNA with molecular analysis revealing PTC rearrangement mutation. So what is the next step? I think this was covered already in our discussion today. So the correct answer is option B, referral for total thyroidectomy. Because the presence of RET-PTC mutation, it has a very high positive predictive value. The chances of malignancy goes to as high as 80 to 90% or even more than that. And so the correct answer is referral for total thyroidectomy. And the fourth question is about the regarding the active surveillance, and the question was asking regarding the true statement amongst all these. So what is the true statement? The true statement is option D. The presence of parathyroid disease which requires surgery is an indication for thyroid surgery. All the other options are actually in fact not true. So these are some of the indications for this for surgery in papillary microthyroid carcinoma. These include presence of clinical lymph node metastasis or distant metastasis, clinically apparent invasion into the recurrent laryngeal nerve or trachea, diagnosis of aggressive subtype of papillary thyroid carcinoma, and the tumors which are adherent to the trachea or along the course of recurrent laryngeal nerve, or if the tumor is associated with other thyroid or parathyroid disease requiring surgery. And the fifth question was the most common genetic mutation in congenital hypothyroidism due to dyshormonogenesis. So the correct answer is DUOX2 gene mutation. This is an enzyme mutation in this gene. It can impair the production of thyroid hormone. So that is why it is the most common cause. The rest are on PAX gene 8. PAX gene 8. This is mainly related to thyroid dysgenesis. That is the developmental abnormality, but not the dyshormonogenesis. Similarly, NKX21 is also related to the thyroid dysgenesis. And question 6 was where the patient was receiving multiple radioactive iodine doses to control the disease, where the patient had the lung mets. And the correct answer includes increased risk of dental caries. Why this happens? One of the most common adverse effects of the radioactive iodine therapy is salivary gland damage. This can lead to salivary gland pain, swelling, infections, and stones, and decreased salivary production leading to xerostomia. and this xeroxtomia results in excessive dental caries. Studies have shown up to 40 to 60% of the patients can have salivary gland dysfunction. And the patients can also experience difficulty eating certain foods and even challenges in talking for longer intervals if the patients are given multiple doses of radioactive iodine. And the next question is, which of the following statements regarding the production of iodine 131, the correct answer is option B. Iodine 131 is produced by neutron irradiation of tellurium. This is just a fact statement. And question 8, this also has been covered in Dr. Madhukar's talk. So which statistical features qualify for rule out test? The correct answer includes option A, high sensitivity and high negative predictive value. It's basically the ability of the test to determine correctly the absence of the disease. So in the context of thyroid, so it helps us to reassure the patients that there is no malignancy in thyroid nodules. In contrast, tests with high specificity and high positive predictive value are good to rule in disease. And question 9 is regarding Barrett's index. And the correct answer is it quantifies the enlargement of extraocular muscles within the orbit to assess the thyroid eye disease severity. Basically, this is an measurement made on CT or MRI. Horizontal index and vertical index are measured. And the interpretation being a Barrett's index of more than 60 is highly sensitive and specific to suggest dysthyroid optic neuropathy. Less than 50% rules out the optic neuropathy. This is the Barrett's index. And the last question again, which has been covered in Dr. Madhukar's talk, which thyroid nodule test has two-step testing process? The correct answer is option C, Thygen Next Thyra MIR. So that brings us to the end of the quiz.
Ma'am, we have the winners ready.
Yeah, sure.
If you can allow, yeah.
Sure, I'll just stop sharing the screen. Yeah, I stopped sharing the screen.
Thank you. So the quiz winners for the DM endocrinology residence, the first place goes to Dr. Parag Agarwal, who's got a score of 5 out of 10. And the second place goes to Dr. Siddhartha Chakravarti, who's got a score of 4 out of 10, as does Dr. Abhijit, who holds the third place with a score of 4 out of 10. Now, when two people have got a score 4 out of 10, we look at the time they took to react to give the answers. So thank you, Dr. Sumana, for the quiz, and congratulations to all the participants and the winners as well.
Thank you.
Thank you, ma'am, for leading a very engaging quiz. Madam, definitely your detailed explanations were enlightening. So as we conclude today's session, I'd like to thank Dr. Ashwini for taking us through this very interesting case, even with clavicle metastasis and locally advanced cancer as well, with a survival of about 3 years with TKIs. I would like to extend a special note of appreciation to Dr. Amit Agarwal sir and Dr. Pooja ma'am for moderating the session in a very engaging way. And special thanks to Madhukar sir for enlightening us on the role of molecular testing, which definitely can be considered as a groundbreaking innovation in the management of thyroid cancer. Sumna madam, your quiz has been very thought-provoking to all our residents. Thank you, ma'am. So we hope this session has been very valuable and informative for all of you. So our next Thyroid Clinic session is scheduled for the December 11th. So we look forward again to welcoming you all for a Thyroid Clinics which is filled with knowledge and insights. We again invite you to submit your research on the thyroid disorders to our flagship journal, that is Thyroid Research and Practice, by scanning the QR code. We also invite you to pick up a reviewer for the Thyroid Research and Practice by scanning this QR code and help maintaining the high standards of our journal. So thank you all for joining, and we'll be pleased to see you all on December 11th.
Thank you so much. Thank you.
तस्य भासय सर्वमिदं विभाति